It is my distinct honor and privilege to introduce our next presenter, Dr. Francesca LaVecchia. I'm going to read her bio because it's a long one and I didn't have time to memorize it. Dr. LaVecchia is a senior level clinician with 50 years of experience in the field of clinical neuropsychology and has held clinical supervisory positions within the continuum of programs serving adults and children with both acquired and congenital neurological conditions, including acute trauma care, interdisciplinary rehabilitation, neurobehavioral psychiatric treatment, and community-based post-acute care. From 1985 to 2013, Dr. LaVecchia served as chief neuropsychologist for the Massachusetts Rehabilitation Commission. In that capacity, she was instrumental in the development of clinically informed community-based services for individuals with acquired brain injury, including the Massachusetts statewide head injury program. Dr. LaVecchia was also responsible for clinical oversight and supervision of program coordinator staff and assisted in the development of clinical eligibility protocols, as well as services and programs designed to meet the needs of Rowland and Hutchinson class members served by MRC. She was also responsible for developing clinical policies, including risk assessment procedures for ABI and MFP waiver participants. Currently, Dr. LaVecchia is a clinical consultant and the director of clinical education for the Brain Injury Association of Massachusetts. With respect to her faculty appointments, Dr. LaVecchia served as assistant professor of anatomy and cellular biology at Tufts University School of Medicine, where she was a member of the medical neurosciences teaching faculty for 25 years. She is an adjunct assistant professor of psychiatry at Boston University School of Medicine, where she was a member of the behavioral neuroscience doctoral program core faculty from 1984 to 2020. Dr. LaVecchia, the floor is yours.
Good afternoon, everybody. First of all, I wanted to just start off an introduction to what I'm going to be doing today as part of the several trainings that are going to be related to rolling out the principles of engaging in waiver services. I'm particularly today going to talk with you about the acquired brain injury population. And what we're going to do today is start with an overview of acquired brain injury and just kind of going through the basic categories of acquired brain injury, as there are some people that are just starting to work with both Mass Rehab and DDS, and just to kind of have a definition of that. And then we're going to talk about common neurobehavioral and neurocognitive disorders that are associated with acquired brain injury and their relationship to the types of brain injuries that people have, the sites of injury to the brain, and the severity of injury. And given that our focus here is going to be on rolling out the principles, we're going to talk a little bit about the impact of neurobehavioral disorders with respect to communication and social interactions and modulation of behavior and perception. And our whole goal here is to really kind of form a foundation that would inform the rolling out of the principles, explaining them to the people that are served. And really, the idea was to really, I think, all the group that has been working on developing the principles and also this training series was that everyone would kind of receive some additional education to really make the rolling out of the principles successful, and what we might need to do and think about in terms of individual client needs and how we can best approach them with the principles. So that's our goal today. And some of the things I'm going to go over today are also going to tie into our third session, which is going to be case studies. And at that time, there will be two individuals that will be presented as part of case studies, both of whom have very significant acquired brain injuries with very significant neurobehavioral disorders. And so I will kind of set the stage with that with some of the didactic presentation today. Okay. All right. So first, let's start off with what we mean by acquired brain injury. And of course, having had an acquired brain injury was the primary clinical criteria for being included in the acquired brain injury waivers. And some of you were around since the beginning of those waivers also know that there were some people who were exceeding the cost cap when the acquired brain injury waiver was first rolled out. And so that when MFP came online, many people with acquired brain injuries also ended up in the MFP waiver, which of course is going to have a much wider range of disabling conditions and disorders that those individuals are going to exhibit. And when we reconvene next Tuesday, there will be a presentation on the range of disorders that are represented in the MFP waiver. But today I'm going to stay focused on acquired brain injury. So the basic definition then of acquired brain injury, this is something that occurs postnatally. And here we have some of the major categories of acquired brain injury, which include infectious disorders of the brain when people have meningitis or encephalitis from a variety of infectious agents. We have brain tumors or neoplasms, central nervous system neoplasms, and individuals may have a brain tumor that arose out of brain tissue, and we call that a primary brain tumor. However, it may be that people that we're serving now, that they didn't maybe have a brain tumor at the time that they were determined eligible for any of the waivers, but maybe developed one later because people can also develop secondary brain tumors that are related to the fact that cancer from another primary site has metastasized to the brain. And I'm certainly aware of individuals that after we placed them in the community, that they did not have a brain tumor, but then having had the same risks as the general population, they developed cancer with metastasis to the brain. So that's something that can happen later and after placement. Metabolic disorders is a very large category of acquired brain injuries. And if we had to look within that category, probably the largest subcategory would be individuals who have anoxia, where they've had their brain injury due to a lack of oxygen or diminished oxygen levels. And this can range from anything from people who have had a cardiac event with secondary effect on the brain. We have individuals who have had overdoses and have ended up with anoxic brain damage as a result of that. But again, a very wide range of conditions fall under metabolic. Neurotoxic disorders, many of the individuals that we serve may have a primary neurotoxic disorder, is that their brain injury was due to toxicants, and others have it as a comorbid disorder that is associated with another type of acquired brain injury. Again, large group of disorders and with very specific consequences of those disorders related to whatever the toxicant was. Stroke in neurovascular is the second leading cause of acquired brain injury. And we have many individuals who are in our programs who have sustained a stroke. And while most individuals who sustain a stroke are over the age of 60, about a third of individuals who sustain strokes are under the age of 60. And we do have many young people who have had strokes at times, again, due to drug use, and at other times because they have a structural malformation in their brain that has resulted in a stroke at an earlier age. The leading cause and the most frequent diagnosis that we see on the acquired brain injury waiver is traumatic brain injury. And again, this is a leading cause of acquired brain injury. In Massachusetts, we see over 70,000 new traumatic brain injuries in Massachusetts annually, and over 2.7 million at a national level. And again, many causes of traumatic brain injury, which include motor vehicle events, assaults, and other mechanisms for traumatic brain injury. But right now, overwhelmingly, the majority of people who sustain a traumatic brain injury sustain that traumatic brain injury secondary to a fall. So when we think about, factors that are going to affect outcome and are going to affect someone's neurocognitive status after they've had acquired brain injury, or particular types of neurobehavioral disorders and neuropsychiatric disorders after brain injury. There are multiple factors that are going to influence that outcome. One, of course, is age and your ability to recover from an acquired brain injury. The sites and the severity of the neurological insult that one person has sustained. And you might see that there are focal injuries to the brain, or in some instances, there are multifocal injuries to the brain, or sometimes people have a diffuse impact to the brain, such as coming back to the cause of brain injury being anoxia, as the brain requires about 25% of your oxygen supply. And so we have diffuse impact of anoxia on the brain. Although what we see too is that certain cell populations within the brain are more vulnerable to the effects of anoxia. And so again, these are some of the factors when we think about sites and specific types of syndromes that people have a lot to do with what areas of the central nervous system are impacted. Lateralization. Many injuries are going to be primarily maximized in the left side of the brain. Others are going to be maximized in the right. Some are going to be bilateral. And so we see different types of neurocognitive and neurobehavioral syndromes related to the lateralization of the brain injury. The specific disorder or disease is going to influence neurocognitive and neurobehavioral outcome. Velocity is another factor. So whereas many people that we see have what we call a static brain injury, is that they had a brain injury, they went through a period of recovery, and now they are left with residual sequelae or deficits. Whereas other disorders might be progressive, and as they go on in time, we might see that their neurocognitive and neurobehavioral status is going to diminish. And so we're going to touch back on that a little bit later in the presentation when we think about why might people's behavior change and lead to some of the disinhibited syndromes that we see. All right, other factors, nature of complications, in addition to the actual neurological insult itself, the presence of premorbid conditions, that is before they had an acquired brain injury. Did that person have a psychiatric disorder before their brain injury? Did they have a developmental disorder? What was their overall medical status before they sustained an acquired brain injury? And all of that is going to be contributory with respect to outcome. Participation in rehab is also, of course, a demonstrated factor in terms of how well people are going to do post-injury. And, we know from studies we've done, particularly in Massachusetts, on looking at people getting discharged from hospitals after sustaining acquired brain injuries. And we looked at this several years ago across multiple types of brain injuries. And what we saw kind of overwhelmingly is that in this day and age, that most people have very short lengths of stay. Even if somebody got admitted for a severe traumatic brain injury, they were typically in the hospital for a mean of 7 days. And the majority of folks did not go on to go to either a rehab unit or a rehabilitation hospital. And I think what's particularly relevant for the folks that are on the waivers, either one, MFP or ABI, is that they ended up in nursing homes or chronic care facilities, and that they were there after their brain injury and went into a facility that really did not typically have a full neurorehabilitative team there that was going to provide the kinds of rehabilitation that one should be provided in those acute stages. And so unfortunately, we've seen a lot of, and I know you know this, that when you go into, do your first assessments, when we're considering transitioning people to the community, you know that a lot of the problems that they exhibit physically and medically and so forth is really resulted from the fact that the types of disciplines that would be called into play to facilitate someone's recovery from a brain injury are typically not on the staff of these facilities, and they are often left with secondary disabilities. And we also saw this, those of you who worked on the Rowland lawsuit, that these were children that went into nursing facilities and stayed there until their adult years. And at the point that we were transitioning them to the community, that many of them had many physical disabilities and other kinds of impairments that were not addressed at the time that they were in those facilities, which left them with, unfortunately, severe compromise, which otherwise could have been had a different outcome. So I think it's important to point that out, because when we talk about neurocognitive problems, neurobehavioral problems, I can say with great confidence that these things are typically not addressed in nursing facilities or chronic care hospitals, and they're not assessed. And so if you're not having your neurocognitive problems evaluated, and you're not thinking about compensatory cognitive strategies, and people then develop inappropriate ways of dealing with their cognitive deficits. And what my experience has been is that in those facilities, people have significant neurobehavioral problems, and they're not bringing in neuropsychologists and neuropsychiatrists to address those things. And essentially, they're giving them a lot of medications, oftentimes polypharmacy, with the intent being to subdue them and to largely keep them quiet in those facilities. And these are not in any way the best psychopharmacologic approaches to dealing with neurobehavioral problems. And so now when they get transitioned to the community, and depending how many years they were in those facilities, there may be a habit strength to a lot of what you're experiencing with individuals when they come to the community. And in many ways, it's really kind of starting at the beginning of trying to assess things that should have been assessed or addressed long ago. So I think that's, just an important thing to point out, particularly for the waiver participants. Okay. Other post-injury risk factors include substance abuse disorder. What was their psychosocial history prior to having a brain injury? What was their post-injury status? How many of them were homeless before they maybe ended up in an institutionalized setting? And of course, all the waiver participants are coming from institutionalized settings. We also have the issues of late effects and post-acute disorders. And so people can develop, for example, seizure disorders long after they've had their initial brain injury. And oftentimes those things may be just attributed to neurobehavioral problems, or that they're willful behavior, when in fact they have a seizure disorder that hasn't been evaluated. And sometimes they have had behavioral problems related to a procedure that was perhaps done acutely, like putting in a shunt for excessive hydrocephalus. And actually, I thought to just kind of mention this because I have seen it very often. Here we have an image of the inside of the right hemisphere and the right side of the central nervous system. And what we see here in the middle are, the cells that make cerebral spinal fluid, which you make continuously. And due to acquired brain injuries, again, swelling in the brain, pressure on the brainstem, pressure on the system, people can develop hydrocephalus, a blockage. And I've wanted to just mention this today because not only that all by itself can cause neurobehavioral and neurocognitive compromise, but let's say it's been shunted and that individual has had a shunt put in to control the hydrocephalus, and maybe it's been there for a while, but now, they are having an emergence of neurocognitive and neurobehavioral problems. And again, when somebody has a shunt for hydrocephalus in their head, and we're now seeing the presentation of new problems, which can include the kind of disability we're going to talk about today. This is another thing that should come to mind as a kind of a first step in ruling out the fact that the shunt is maybe malfunctioning, and that could be at the base of what we're seeing as a behavioral change in behavioral status. Okay, so just again, concludes my brief overview of acquired brain injury, the categories and some things that are going to affect their neurobehavioral neurocognitive outcome. And now I just wanted to talk a little bit about what those specific neurocognitive deficits might be as related to acquired brain injury. And we're going to focus more on neurobehavioral as we go through the rest of the presentation. So one of the things I think we have to think about as we think about presenting not only the principles, but probably anything that we are going to present to the waiver participants who have acquired brain injury is what is their neurocognitive status? And as I mentioned, I think the vast majority of people that we transitioned to the community had never had their neurocognitive status evaluated after their acquired brain injury. And so when they're coming to the community, this is not information that was readily available to provider staff or to you or to anybody else that's going to be working with that individual. But I do think it's important in terms of thinking about how this is going to inform everything that you do with that person, is really understanding what their skill levels are that they have retained and what are those areas that they are challenged by, and how can we best use cognitive strategies to facilitate their best functioning. So just as a brief overview, we have that for some acquired brain injuries, dementia is going to be the cognitive outcome. And we usually see this in acquired brain injury where we have typically frequent events or repetitive events. So we can have, for example, somebody who has a stroke, but then has another stroke and maybe has several strokes and could have multi-infarct dementia. And so this can happen in the course of an acquired brain injury. One that I'm sure you've all heard of because all the seminal work for it is being done in Boston is a chronic traumatic encephalopathy, which is primary contributor to that is multiple incidents of head trauma. And so that is another thing that can lead to a dementing disorder. Intellectual disability can be the neurocognitive outcome, particularly when we have early onset of severe acquired brain injury. And again, probably one of the kind of classic examples of that would be children who have been the victims of shaken baby syndrome or shaken impact syndrome. And overwhelmingly, those children, if they survive, and 50% of them don't survive, but if they do survive, those children are left with varying degrees of intellectual disability. And so that may also be an outcome. And those are individuals that may be, in fact, involved with the Department of Developmental Services early on in life because of the magnitude of their injury, and as well as, at Mass Rehab with the statewide head injury program. Most of the individuals that we see who sustain acquired brain injuries, however, have specific neuropsychological deficits. And those require specific, and I say this not just because I am a neuropsychologist, but it is the evaluation of choice when somebody has an acquired brain injury. And these are tests that were developed specifically to evaluate functions and structures and behaviors that are related to the sites and severity of injury to the brain. And that is what differentiates a neuropsychological evaluation from, let's say, an evaluation of general intelligence, which neuropsychologists will also give evaluations of general intelligence, but it's really drilling down to what are the specific types of deficits that are related to the acquired brain injury that is elucidated through a neuropsychological assessment. So again, beyond the scope of what we're doing today, but just to highlight what are the domains that a neuropsychologist would be looking at in people with acquired brain injury. And these would be giving tests that are specific to attention and arousal, learning and memory, constructional and visuospatial skill, language and communication. And of course, that also in a rehab team would also be evaluated by a speech and language pathologist. And because again, this is when you think about social interaction, this is a very critical assessment to really think about how we communicate with people, how they understand us, how we understand them, and how we can facilitate their social interactions in the world. So again, this is a complicated area and not something that we're going to be going over today, but I really want to point out that if people have brain damage that is maximized in their left cerebral hemisphere, that they are going to be at risk for developing various types of aphasias. And some of those aphasias are fluid, and some of them are non-fluent, and some of them involve deficits in comprehension, others expression, sometimes both of those. And so again, a comprehensive aphasia examination is critical to assisting that person as well as the people that work with them and how best to communicate with them. And so again, this is just a summary slide of areas of the left side of the brain that would lead to various types of aphasias. Okay, other domains that are evaluated in a neuropsych assessment would be perception, praxis, their ability to follow commands, academic skills. And again, we'll come back to this in terms of some recommendations at the end, but getting a handle on someone's reading capability, their spelling capability, their basic understanding of written material, I think is going to be critical to having them understand the principles and any other documents that, I think that we provide to people with brain injuries. And again, these particular skills are going to be disrupted by with those same areas that we just looked at in the previous slide, because these are functions that are primarily, for most people, located in the left side of the brain. Executive skills, we're going to talk about a little bit more today in more detail, but what we mean by that are our higher level cognitive functions like reasoning and problem solving, and our ability to be cognitively flexible. And of course, one's mental status is also another area to be evaluated either by a neuropsychologist or a mental health clinician, and that is also going to have an impact on behavior. So now it's the first time we're kind of looking at this slide, and by Dr. Frank Netter, and which you may have seen at other times. So here at the top, we're looking at an image of the left side of the brain. And again, this is an image at the bottom of the inside of the right side of the brain. And we're going to come back to this image a few times, but for now, I wanted you to just kind of focus on some of these areas that are in darker colors, like this dark blue, purple, and this area here in the occipital lobe and here. And these are the primary sensory areas in the brain. And so again, these may also be disrupted by a brain injury, an acquired brain injury. And so again, loss of hearing can happen, for example, with shaken baby syndrome, also happens with different types of traumatic brain injuries. That was a common thing that we saw, for example, in veterans who were exposed to IED blasts, that they would lose their hearing and have other auditory problems. Olfactory, anosmia. I think everyone's heard a lot more about anosmia in the news over the last 2 years as one of the symptoms that you see in COVID. And both initially and during initial infection, and also, this is something that can last for a while, if not permanently. And this is a common problem after traumatic brain injury because of the area of the frontal lobe that is often impacted by head trauma. Tactile damage to the postcentral gyrus, which is that blue area and the area that we just, the slide we just looked at, again, causes one to have loss of sensation on the opposite side of the body. And vision. The optic nerve is one of your cranial nerves that goes through the entire cortex. And so again, beginning at the back of the retina and going all the way back to the occipital lobe, as you see here. And we can have different types of visual impairments based on exactly where on the visual pathway one has had injury. And this can happen in a variety of neurological disorders and acquired brain injuries. And so again, very often individuals are not aware that they have these visual field impairments. And certainly it's not been my experience that when they were in institutionalized settings, that they ever had a neuro-ophthalmology examination. And so they may have these problems and not realize that they have them, and they have never been evaluated. So this is, again, just another thing that can be related to acquired brain injury as a consequence of acquired brain change. So I have to say, tasked today with talking about neurobehavioral disorders. And to do this in the time we have available to us, I kind of thought about some of the particular neurobehavioral disorders that I wanted to emphasize today. And some of them I'm going to hook up with some current research on the brain. And I wanted to just, give you just an idea of some of these disorders, and also what they have to do with site of injury. Okay. And so let's start with agnosia. Okay. And agnosia, there are many types of agnosias, but basically it's the inability to recognize sensory information. You see it. I'm going to start with visual agnosia. In other words, you perceive sensory information, but it's kind of been stripped of its meaning. And this should be an agnosia is not, in other words, things you got to rule out for an agnosia is that person does not have a sensory loss. You got to make sure that they don't have aphasia and they don't understand what it is that you're asking them to do. You wouldn't call it agnosia if it was occurring in the context of someone who has generalized dementia or a generalized condition that's affecting their mentation. This is typically modality specific. And so we're going to take a look at one of them today. I'm going to tie it in with a couple of other syndromes. And so we'll talk about visual agnosia today. And some of you may know this book by Dr. Oliver Sacks, the late Dr. Oliver Sacks, who wrote many books about particular types of neurological and neurobehavioral disorders. And the catchy title refers to the fact that one of the cases reviewed in this book was an individual, a very bright individual, who had visual agnosia. And in the book, and during a clinical encounter, he actually attempts to pick up his wife and put her on as if she were a hat. And of course, he had many other disorders associated with this. So let's talk a little bit about visual agnosia. And so what it is that you have an inability to recognize an object. You see it, but you no longer recognize it. And if you test these individuals, their perception, their acuity, their visual fields that we just talked about, their ability to scan, this is all adequate. So when might you start thinking about this? Well, in people who have strokes that affect the occipital lobes of the brain where vision is located. And what else might be associated with visual agnosia? Well, that person may have lost their ability to read, so they have dyslexia. And they might have a type of visual agnosia, which is called prosopagnosia. And we're going to talk about that a little bit more today because it's something difficult for us to understand sometimes because we're not experiencing it. For that person sees you, but they don't recognize you. And prosopagnosia, as it's typically defined, is really for people that they don't even recognize the members of their own family. And incidentally, it can also cross race. They will make racial mistakes in terms of identifying what race that person might be because of prosopagnosia. This may also be associated with achromatopsia, and this is loss of color perception. And to tell you how complicated that might actually get, that person might even have only loss of color perception in half of their visual field. So they perceive form, but they don't perceive the color. So I think you can realize that these are fairly complicated disorders, but that you might start thinking about them based on what that person's acquired brain injury is. And we're going to come back to that issue of prosopagnosia in a little bit, but I wanted to just, introduce it here. Anosognosia. So let's talk about this syndrome, because again, this is kind of a classic syndrome, I think, where people have behaviors that are really the result of exactly where their brain injury is. So this is more a disorder that is typically observed with people who have injury to the right side of their brain. And these individuals may not even though they could be densely paralyzed on the left side because of the manifestations of the injury are going to be observed on the opposite side or contralaterally. And they don't believe that, for example, that they've had a stroke. They don't recognize that they've had a stroke. They may, even if they're densely paralyzed, they may try to get out of bed or be a fall risk because even though they cannot move that side, they do not believe they've had a stroke on that side. So this is anosognosia. And this can be quite profound, I think, in acute care. And after people get out of the hospital, if you interview them, they may still say that they've never had a stroke. I've interviewed people that they're still in a wheelchair. And in fact, in recent history, I interviewed somebody who was transitioning to the community, and he was brought in to me by nursing staff in a wheelchair. And I said, I understand from reading your record, and nursing staff had also told me that, he doesn't believe he has any problems and he doesn't need to go to a 24/7 residential program. And I sat down with him, and sure enough, he was going to go because, they told him he could get out of the nursing home, but, he didn't really think he had to go to a 24/7 program. And as soon as he got to that 24/7 program, his plan was going to be, he was going to go get an apartment, for which he actually didn't have a plan. And so I said, well, can I just kind of ask you, what, I understand from your record, you had a stroke, and what kinds of problems do you think you're having now after that stroke? And of course, his response to me was he had absolutely no problems. And I asked him, well, gee, no problems. And I kind of went through, do you have any problems with this, that, and the other thing? I got to motor. And of course, he denied all the other problems. And I said, he says, no, I am fit as a fiddle and I don't have any motor problems. I said, well, I see they brought you in a wheelchair. And, I was wondering, do you feel that, you need that wheelchair? He goes, the nurses just brought me in this wheelchair. I don't really need a wheelchair because I walk just fine. Again, hemiplegia, residual hemiplegia on the opposite side. So this can be quite profound. And of course, sometimes a very significant risk management issue. But oftentimes we get back to the community and they'll say that, it resolves this other disorder, anosognosia, where you might say, well, yep, I had a stroke. Yep, and he did not even really get that far with me, but you say, well, I had a stroke, but it's really not affecting me in any way. Or I've made a complete recovery, right? The same individual may also have hemi-neglect, or what we call hemispatial agnosia, where they ignore things from the left side of space. And again, primarily because this occurs in somebody who's had an injury to the right side of their brain. So here we have a kind of a disorder that you can see is really related to the site of injury and can lead to long-term kinds of behavioral disorders. And also, it can also, when you think about presentation of the principles and any other maybe sometimes difficult conversations that you have to have with somebody, this is someone who is going to say to you, I'm not doing that, or I don't have that problem, or I'm not behaving in that way, or to minimize, or to say, well, I made a comment, but I really didn't say that, or it didn't mean this, or so forth. So again, when should your antenna be up for this? Again, it's going to be somebody with a right hemisphere lesion. What you're looking at here is a diffuse tensor imaging that shows you the connecting fibers of the brain. And this is, again, you can see the connecting fibers here between the two sides of the brain, corpus callosum, within the hemispheres, down to the brainstem. And so I just show you this because I think it's a really kind of amazing image to think about the issue of connectivity. So one of the other reasons we have neurobehavioral problems is because of acquired brain injury, we have disconnection that happens in the brain. And you might even have this area of the brain is intact and another part of the area of the brain is intact that are related in a normal brain. But because the bridge is out, because these areas have been disconnected, this leads to very specific kinds of disorders. So I just thought we would, kind of focus on one of these disorders. And so again, just overall, many different types of disconnection disorders. They can happen between the two sides of the brain. Again, the biggest connector there is the corpus callosum. And just to highlight the corpus callosum is those fibers, which are made of white matter, myelinated axons, are particularly vulnerable, for example, in severe traumatic brain injury with disruption of disconnecting right brain from left brain. It can also happen within the brain. It may be diffuse or it may involve specific pathways, and typically it is acquired brain injuries that cause disconnection. So let's take a look at one of those. And we have Kluver-Bucy syndrome. And Kluver-Bucy syndrome has very particular behaviors. And Kluver and Bucy actually first described this syndrome in the 30s, where they induced it in non-human primates. And they looked at how those monkeys behaved. And then, of course, we also see this in the human condition. And what do we see? We see that people they mouth things, both monkeys and humans. They are constantly putting things in their mouth. Humans may also have exhibit bulimia. They engage in indiscriminate sexual behavior, and it may be stimulating, heterosexual, homosexual. In humans, you can see altered sexual orientation. Sometimes that is something that happens when people develop Kluver-Bucy syndrome that they find to be ego dystonic. They may be engaging in the behavior, but they don't necessarily believe that they have changed their sexual orientation. You can see verbal sexual disinhibition and other types of sexual disinhibition of a verbal nature. They're constantly reacting to stimuli in an impulsive manner. Initially, people have a kind of flat affect, but they can be provoked as time goes on. People who survive with Kluver-Bucy syndrome can be provoked or spontaneously engage in episodic aggression. And here's a disorder that is also associated with visual agnosia and prosopagnosia. So this inability to recognize the faces of familiar people. So here we have an agnosia, two types of agnosias in the context of a syndrome. And this is what we're looking at here, is just to kind of show you this. This is a view of the brain. So it's a coronal slice, right to left slice of the brain. Just kind of focus here on the temporal lobes that I'm highlighting here. And this is a normal slice of brain. And now let's look at the next slide. And now you see those temporal lobes are quite damaged on both sides. And this is the type of acquired brain injury that would be more likely to result in Kluver-Bucy syndrome. And so again, this is a visual limbic disconnection disorder. We have the visual system gets disconnected from the limbic system or the emotional brain that leads to those symptoms that we just reviewed. So who's more likely to have this particular type of syndrome are people that have herpes encephalitis. And that slide that we were just looking at, this actually is a slide of a pathology slide of herpes encephalitis. And while other parts of the brain were impacted by the virus, as we can see here, it's the temporal lobes that have this very severe impact as a result of this particular type of brain infection. And so again, when I was first in clinical practice, I didn't see a lot of people with Kluver-Bucy syndrome. It was considered a rare disorder. But now that we have treatments for people who have herpes encephalitis, the natural history of herpes encephalitis has changed. And so you can see this disorder more frequently. It also has been described in people with traumatic brain injury. And as neurobehavioral changes, it can be seen in the early stages of Pick's disease or frontotemporal dementia. And so these are the typical disorders that you can see where your suspicion would go up if somebody is exhibiting these symptoms as to whether or not these are related to the particular types of acquired brain injuries that they sustain. Okay, so those are just a few disorders that lead to very specific neurobehavioral syndromes. And again, just to highlight the idea of lateralization of brain injury, type of brain injury is going to lead to specific kinds of neurobehavioral syndromes. As we now move into things that are more common, okay, things like mood disorders, depression is the most common psychological response and mood disorder in acquired brain injury. But it's important to recognize that this too can be influenced by what side of the brain is injured. So in stroke patients, for example, a stroke in the left side of the brain, particularly one that is more anterior and towards the frontal pole of the brain, the protruding part of the frontal pole, you're more likely to have depression. And it's also been demonstrated that when depression is not assessed and treated, particularly in acute rehab, that this is going to have a major impact on one's response to rehab and also their outcome. And of course, if they end up in an institutionalized setting, this may not be recognized or addressed or appropriately treated. But I am going to go back to some things that also need to be considered about depression in terms of differential diagnosis in folks with acquired brain injury. Mania, on the other hand, is not common. And again, this is more likely observed in people who have right-sided brain injuries, and particularly in these areas of the brain. And so, again, less common, but right-sided. Bipolar disorder, the presentation of bipolar disorder, is also more likely to be observed in people with injuries who are maximized on the right side of the brain. So again, we still see, even though these are more pervasive disorders, that there's still the issue of what type of brain injury and where the brain is injured. And as I said, we also need to think about differential diagnosis. And I want to introduce another term that we're going to talk about a bit more as we look at the frontal lobes, and that is the issue of pseudo-depression. So again, people can appear to be depressed. However, if you do a thorough mental status examination on them, and they will not necessarily endorse that they are depressed, even though sometimes they're being treated for depression. And this is the syndrome of pseudo-depression. And we're going to talk about this a little bit more when we talk about the prefrontal cortex in a bit here. Some people appear to be completely unable to initiate purposeful behavior, including even speaking. And this is the syndrome of akinetic mutism. And again, these folks are also not depressed. This is a disorder that has to do with areas in the brain that are involved with initiation of purposeful behavior, including speaking. So these individuals are not paralyzed and they're not mute, but they appear that way. Okay. You can have pseudobulbar affect. Again, you might be inclined to think this person is depressed. Again, if you interview them, you find that what they have is a lability of emotion. And that lability is oftentimes uncontrolled crying. But we know that this is also related to the brainstem and fibers that are coming down from the cerebral hemispheres to the brainstem. This is a bilateral fiber system. And again, if you interview those folks, and they may often be very embarrassed by the fact that they are unable to control the motoric presentation of affect, but they are really not depressed. So it's important to understand these other presentations before we start medicating people for depression. And again, to recognize that these are related to particular areas in the brain. As another couple of things to think about with depression differential diagnosis, we also could have pseudo dementia. So when people have intractable depression, which has really affected them in almost a global way, they can present, you examine them, give them a neuropsych assessment, they may actually look like they have dementia, but it's typically flat on all domains and not the kind of thing that you would typically see in an emerging dementia with particular domains being more impaired than others. This appears to be a kind of flattening of neurocognitive function. So that might be another thing to think and take into account. And of course, when people have dementing disorders, particularly in the early stages where people are more aware that they have a dementing disorder, can be associated with actual depression. So again, just if we take one domain of psychiatric functioning, which is the mood disorders, and realize that an acquired brain injury, that there are other reasons that people can present as if they have depression. One of the things I wanted to talk a little bit now about is personality change. And again, outside of depression, one of the most common things that is reported after acquired brain injury is a change in personality. So just to kind of have a presentation of what do we mean by personality, which would certainly be a whole nother lecture, but just a basic definition is that what we talk about in terms of personality involves values, belief systems, one's worldview, how people are on an introversion extroversion scale, neuroticism, psychoticism, and other biopsychosocial determinants that may be related to your upbringing, to your experiences, what you've learned. So again, this is roughly what we mean about personality. And of course, there are many other characteristics that would be under the heading of personality. So when we talk about personality changes after acquired brain injuries, there's a number of kind of common ways I think that personalities are changed. One is there can be an intensification of that person's characterological traits. So let's say that this person had a particular way of behaving in the world. Let's say that they were a person that maybe easily flew off the handle, let's say. What we can see after an acquired brain injury is that that particular characterological trait has intensified. So it might intensify, meaning that it's happening more often, it's more significant, it's more severe, and with little provocation. So we could have an intensification of a pre-injury characterological trait. Sometimes what we see is that behaviors are going to be developed de novo, that this person never had this kind of a problem. And what you're seeing now with that person is nothing that was ever observed in that person before they had their acquired brain injury. And I think of a person that comes to mind for me as a young man who was struck down at high speed by a motor vehicle, was left with severe brain damage, bilateral brain damage. And this young man, prior to his brain injury, his traumatic brain injury, was a lovely person, a kind person, never engaged in any aggressive behavior. And as part of his social network, he was involved with a lot of international students. He was white. He had an Asian girlfriend. He was always welcoming of people of diverse backgrounds. Post-injury, and it didn't emerge initially, but it came out within the year of his injury, he actually became more and more disinhibited, aggressive, injuring family members who actually had really become quite frightened of him, including a younger sibling. He started making racist comments. He then joined a neo-Nazi group in Boston. He started hanging out with them. He started writing racist comments on the sides of buildings in the city, spray painting them on there, going through African-American neighborhoods in Boston and provoking people and yelling at racial slurs at them out the windows. This was the complete antithesis of who this person was before their brain injury. And no recognition that any of his behavior was impacting his family, others. Ultimately, this led to criminal charges. He was incarcerated. And again, beyond the scope of what we're doing for the training today, but a very long course of really just dysfunctional behavior after his brain injury. But it had never, ever been there in any way, shape, or form before his brain injury. What we talk about personality changes, we see very often associated with lesions of the frontal lobe. And we're going to spend time talking about those two major syndromes in a bit. And the other thing we have to think about with personality changes are psychiatric comorbidities. Have people had a trauma history? Have they had other psychiatric problems before this? And what other psychiatric things could be contributory to this change in personality? Okay. All right. So now we're coming back to this diagram again. And again, I'm going to call your attention to this area here in the frontal lobe. So the frontal lobe begins right here with this red area, which is the precentral gyrus. Is where your motor skills are. This orange area is the premotor area. And this area right here, this lime green area, which extends onto the medial surface of the brain, this area, which is the most developed among all primates in the human brain, is the prefrontal area. And this is kind of our brain that really has to do with our higher level intelligence. And as we're going to see, also has to do with the modulation and regulation of behavior. So let's go to this slide. And I put in your handouts here a couple of papers that you can access online in case you would like to read more about this. And this is one of them, and it's kind of a classic paper by Dr. Tom McAllister, who is a neuropsychiatrist and one of the co-authors of the book, the textbook of traumatic brain injury. And this is a paper, I think, a very good paper to just kind of summarize what I'm going to go over with you today. And we're going to talk about these two syndromes today. One is this syndrome, the dorsolateral prefrontal cortex syndrome. And this colored area is what we refer to as the dorsolateral surface. And we're going to talk about this area here, which is the orbital frontal surface. And we'll talk about some of these areas to which these prefrontal area is connected. Okay, so that's what we're talking about today. And we're going to highlight this in terms of personality changes after acquired brain injury. Okay, so we will go over in some detail today the dorsolateral prefrontal cortex syndrome and the orbital frontal prefrontal cortex syndrome. And I just wanted to put this in there because there is another pathway there. And I just talked to you about it just briefly when I talked to you about akinetic mutism. And this is called the superior mesial pathway. Okay, but we're going to focus on these two, which are the two that most people talk about when we talk about personality changes after acquired brain injury. Okay, so the dorsolateral syndrome, when we look at these folks, what we see is that if you evaluate them on neuropsychological evaluation, you see that they typically have impairment of their general intellectual level. They have problems with working memory. And if the injury is lateralized on the left side of the brain, that would be verbal working memory. And if injury is maximized on the right side of the brain, it would be nonverbal memory. They have executive skill deficits. So again, if you give them tests in your office, they have compromised ability to establish, maintain, and shift cognitive set, cognitive inflexibility. They often apply the same solution, even though it's incorrect, to solving tasks, and they may have a perseverative approach to that. And these are some of the typical cognitive issues that you see with people with this syndrome. They have diminished fluency, verbal, if it's a left hemisphere injury, or sometimes it's a bilateral injury that leads to diminished verbal fluency. And this can be seen on particular tests that you would give in a neuropsychological assessment. And if the injury is maximized on the right side of the brain, they might have design fluency. Again, another type of neuropsychological examination. If both on testing and on taking a good history on how that person is functioning, you will find that they often have compromised capacity for organizing and planning and sequencing. Behavioral manifestations of the dorsolateral syndrome, people might be inclined to call this, they say, well, they don't want to do anything. And this is really the disorder of diminished motivation. They seem to be indifferent. They seem to be, quote, not motivated, but this is being driven by neurological substrates. They have abulia, which means they have difficulty making decisions. They have difficulty initiating and sustaining purposeful effort. They're less spontaneous. They might have psychomotor slowness. Their affect is often stimulus bound, so is their behavior. So when you think about these individuals and you think about behavior and maybe the influence of other people, they are more at risk, not so much for being the one that initiates inappropriate behavior, but sometimes they are provoked to exhibit inappropriate behavior because their behavior is influenced by other people. And they classically present with, as we talked about earlier, pseudodepression. And at the same time, these individuals can exhibit episodic disinhibition. And again, this is also often related to the fact that the injury that the person sustained is one that is not a neat, clean. It's only going to be in one area of the prefrontal cortex, but may involve a mixture of the other parts of the brain as well. So that's the dorsolateral syndrome. And the other syndrome here, what we're looking at is the base of the brain. And so again, this is an actual brain. So these are the frontal lobes here. So this is the orbital frontal syndrome that we're going to talk about now. And this is the orbital frontal area of the brain. And these are the folks that I think are more likely to exhibit the kinds of behaviors that the principles were meant to address. And we'll look at, this is a normal brain. And let's look at the next slide. And this is a traumatic brain injury. And as you see, the traumatic brain injury is bilateral. But in this individual, again, if we flip this brain up, this is the right frontal area. This is the right temporal area. You also see damage here on the left side of the brain because traumatic brain injuries are typically bilateral, but they're often maximized in one hemisphere or the other. So this person, had they survived, would have been one of those people that you would have had concerns about their disinhibited behavior. And this is, again, the orbital frontal syndrome. So what do you see with these folks? Well, when you examine them, they typically have their general intellectual level is typically within normal limits. They can have relatively preserved performances on domain-specific neuropsychological tests. But if you look at their behavior and what gets reported to you about their behavior, either by family members or staff, or you observe it, is that they have compromised insight, they have compromised decision-making, planning, and judgment, okay? So even though you may not even capture that on a neuropsychological assessment, these are things that it's important to take into account in good clinical history taking. All right, other things that we see with folks who have the orbital frontal personality disorder is that these individuals tend to be impulsive. They have a diminished capacity for anticipating or recognizing the consequences of their behavior, and that either to themselves or to other people. They are often irritable. They are emotionally labile, again, with minimal provocation. They can engage in inappropriate jocularity, and oftentimes very juvenile joking. They can actually have stereotypical and correct manners, but that doesn't necessarily reflect how they are feeling towards somebody. They're typically behaviorally inflexible. And in fact, these terms, acquired sociopathy, pseudo-sociopathy, or pseudo-psychopathy, these older terms actually come from the lobotomy literature, where people were actually received psychosurgery We still have some people that are in programs across the Commonwealth who actually did receive a frontal lobotomy. And if you looked at people who had a lobotomy procedure, they often fell out into these two categories post-lobotomy procedure. Either they looked more like that dorsolateral syndrome, or they look like this. And so these older terms are still around in terms of people with frontal lobe injury. So lack of empathy and concern for others presents very narcissistically, a lot of disinhibited behavior and emotional dysregulation. And that can be reflected in a variety of ways, verbally, physically, sexually, and sometimes a combination of those things. Their social judgment is poor. They can be very socially and or physically intrusive with other people. And sometimes this is associated with a kind of euphoria, a hypomania to a mania. And again, more often you see that particular symptom when this injury is maximized in the right hemisphere versus the left. So these individuals, again, I think as we have kind of thought about, presenting the principles and the impact their behavior might be having on other people, again, these are some of the people that I think one is going to need to plan for in terms of presenting the principles and how they're going to be received, and what you might need to do in terms of strategizing for the presentation of those principles. Just a word about verbal disinhibition, which is a lot of what we have been talking about in terms of the development of the principles. And as you can see, it can be associated with physical behaviors as well. But just to focus on verbal disinhibition for the moment, what we see in verbal disinhibition is the diminished capacity to regulate what you're saying. And sometimes this can even manifest itself as big explosive outbursts. And so there may be also compromised capacity to appreciate boundaries, and people can be verbally intrusive. They ask inappropriate questions, they make inappropriate comments. The use of vulgar, racist, sexually disinhibited language is also part of a syndrome of verbal disinhibition. And it's also important to recognize that sometimes this represents the onset of neurodegenerative disorder. And while people who were determined clinically eligible for the acquired brain injury waiver, one of the things that was one of the clinical eligibility requirements for the acquired brain injury waiver is that someone did not have a primary neurodegenerative disorder. So if somebody had a primary neurodegenerative disorder, they were not eligible for the ABI waiver. But it's important to recognize that some of the people that are in the ABI waiver may now be at risk because of other factors for developing a neurodegenerative disease. And so changes in their behavior as they age, and again, just something to kind of raise a question about if you're seeing that their verbal disinhibition and other behaviors have changed. Aggression in people with acquired brain injury is typically reactive in nature. It's often in response to a minimal stimulus or provocation. It's usually not planned. It's not premeditated. It's not goal-directed. And it can be episodic. So people can be fine for a good period of time, and then they can have, again, because of something that they perceive as provoking them, can have an episode. And sometimes that episode can be directed at other people, particularly those people that are charged with working with them or providing their personal care or other services to that person with an acquired brain injury. This kind of behavior may be associated with either no remorse, or it can be associated with exaggerated remorse. And so there is this kind of cyclical thing that can happen with aggressive behavior in people with acquired brain injury. And in fact, that was the old term for it, was episodic discontrol. And for some of those individuals, after they engage in this behavior, they plummeted into a depression. And at times they have also tried to harm themselves after they have engaged in this behavior, particularly when they view the behavior that they exhibited as being ego dystonic. So again, this is an important, I think, characterization of aggressive behavior in people with brain injury. And it is not the kind of thing, as you would see, that's why you see those terms, pseudopsychopathy, pseudosociopathy. It is not sociopathic, it is not psychopathic, but it is something that has a different kinds of clinical characteristics to it. I also want to talk about learning. And the behaviors that people exhibit, whether they have brain injuries or not, are also based on learning. So what were the belief systems and biases, prejudices and stereotypes of that person's family of origin? And as I understand from helping to prepare for this presentation today, that we have certain situations that are occurring where the family's significant others, other contacts with that person are contributing to that person behaving in a prejudicial way or a racist manner with staff working with them. So that's something, again, I'm going to come back to at the end of the presentation, but it also may be there in that person's learned behavior that they had before their brain injury. What is the influence of those beliefs with respect to the development of that person's beliefs, viewpoints, and behavior? What was the history of their prejudicial behavior? Was this a person who was overtly racist before they had their brain injury? Or was this a person that perhaps held those beliefs, but because they did not have injury to their brain, they were able to modulate them? And this ability to modulate what may be there under the surface may have been present before they had their brain injury. But now, after their brain injury, their capacity to modulate that behavior, that inappropriate behavior, has changed, hence the disinhibition. And there's more written about this, I think, less in the acquired brain injury literature, but it actually has become a big topic in facilities that are working with older adults who have Alzheimer's disease and other types of neurodegenerative diseases. And because, again, many people of color work in nursing homes where these behaviors are emerging and having a significant impact on the staff. And it's really, and I'm seeing even, books that are coming out about this and papers and guidelines in the geriatric literature for, what do you do when the person who has a neurodegenerative disease is making racist and inappropriate comments and sexualized comments and primarily it's been in long-term care facilities and nursing facilities. So again, here we have a brain that is deteriorating. And so that person's brain is going to have significant impact on their ability to learn to do something different. But I want to come back to the idea that perhaps we can think about this in terms of people with acquired brain injury if they don't have a neurodegenerative disease and what we might do to intervene. Okay. So another thing, just from general literature on kind of the social brain, and again I put this in here. Again, you can just take this paper offline. The DOI is up there. And in people who don't have brain injuries, and if you look at neuroimaging studies where you're looking at fMRI studies where people are being asked to do tasks and looking at how they perceive race and racial groups in people who don't have brain injuries. And if you look at this slide here, you might notice that that pathway is involving some of the areas that we are now talking about, okay? About, in the frontal lobes, in the dorsolateral and orbital frontal lobes. So again, this is a paper that if you're interested just to read it, but again, I just thought of interest to see that, this literature is also those same areas. And another paper that I put up for you in case you would like to read it. Dr. Amodio is one of the experts in the United States of looking at the neuroscience of prejudice and stereotyping, again, in people who don't have brain injuries. So, and he has classified what is, defining in his work, prejudices, attitudes, emotional responses, preconceptions, often negative, about groups and individuals based on their social, racial, or ethnic affiliations, stereotypes. What are the characteristics, traits, attributes ascribed to a social group, such as poor individuals? And so kind of looking at this literature, again, looking at fMRI studies, and this is why I wanted to come back to the idea of face, and I spent some time talking about how the brain perceives face, because in this literature that's not on brain injury, again, perception of the face and its relationship to social interactions and motivations, that again, prejudices and stereotypes may alter face processing. And again, if you look at fMRI studies, where you look at what they perceive as their racial outgroup, in other words, they're not of your racial group, and your in-group and how the people in the people not in your racial group are viewed as threatening and may elicit a vigilant response. And that there's been a core neural network for experience and expression of prejudice that has been outlined in the brain. Again, this is from Dr. Amodio's work, again, that paper, if you want to read more about it. But again, if you look here, same areas that we've just been talking about, right? Is, where is empathy and mentalizing? Looking at these subcortical structures like the amygdala, which is part of the limbic system. And again, looking at that orbital frontal cortex and what its role is in the prejudice network. And this is in an uninjured brain. Dr. Amodio also emphasizes in his work, because it's not that, because I think initially when some of this work came out in the literature, people were saying, well, see, it's about your brain is hardwired to be racist. And that really is not the case. Your brain is not hardwired to be racist. And that's a real misinterpretation of this information. So what we see here, and I like Dr. Amodio's use of the term, the egalitarian brain, which is, that the egalitarian brain, that is the belief that, all people are equal and deserve the same level of respect and opportunities and rights, the egalitarian brain. And this is one of the things he talks about, is that, yes, we have a part of our brain that is connected to those frontal lobes, which is when it perceives something that it views as a threat, that old part of the brain, which has been there since the evolution of the human brain, is reflexive in nature. And it really taps into that fight or flight part of your nervous system, and aptly deemed the reptilian brain. But as the human brain has developed over the course of evolution, those big cerebral hemispheres that I've been showing you overlie that reptilian brain. And of course, is a much more complex structure, the neocortex, that is layered over that reptilian brain. And so again, human beings have the capacity for overcoming their fears and expression of biases. And I would add to that includes people with acquired brain injury. And so that we shouldn't just get to that point to say that this is the way this person is. And even though I'm talking to you a lot today about what the brain has to do with why people are behaving the way they're behaving, that doesn't mean that they can't learn to behave in a different way, right? And I've seen some individuals that have had the most severe neurobehavioral disorders with appropriate treatment and the appropriate behavioral interventions and sometimes psychopharmacological interventions, that those individuals can learn to behave differently. So we don't need to just give up and say that, well, they have a brain injury and this is the way they're behaving, or we're just hardwired to be racist, because that's certainly not, the neuroscience literature does not support that. So we have to think about what are the alternative strategies that we might use to help people behave differently. Some people develop delusional disorders after their brain injuries. Some people become psychotic after their brain injuries. Some people have post-traumatic stress disorder and other anxiety disorders, particularly when the circumstances of their injury has been associated with psychological trauma, or maybe before their brain injury, they were the victim of childhood abuse and neglect, sexual, physical, whatever. And so again, when you think about that reptilian brain that I just talked to you about, those things, these people are already on trigger set for being fearful. And so again, if this is a complicating factor in the presentation of this person, then this is another thing that I think needs to be taken into account in terms of specific trauma-informed approaches to working with that individual. Some individuals have hallucinations. And again, these are some of the things we're going to talk about in the case studies, are some of the things that are on this slide. But again, just wanted to highlight that all of these types of disorders can happen in association with acquired brain injury. It's also important to note that these hallucinations can occur in any form: auditory, olfactory, tactile, visual. And just like I spoke with you before about this pathway and how people can have different visual losses based on this pathway, the same thing is true for hallucinations. So depending where the injury is on this pathway, we can have different types of hallucinations. And that also could affect their perception. Any types of hallucination can affect their perceptions of reality and may also be something that needs to be taken into account when working with individuals. Finally, seizures. Seizures can be associated with hallucinations in all modalities. Perception can be disturbed in seizure disorders. People can engage in automatisms, which are repetitive behaviors, and some of those behaviors can actually be verbal. So you can have verbal automatisms, and they can just be repeating the same thing, but it could be in the context of a seizure disorder, which may mean why it's not responding to a behavioral intervention. People have also personality traits that can develop as part of a seizure syndrome. And these are the so-called interictal personality traits, that is between seizures. And so again, just to highlight some changes in behavior that have to do with seizures. And seizures and acquired brain injury can onset at time of injury, or they can happen years later when scar tissue in the brain could become a seizure focus. So I hope that today, I mean, I know this was a lot to go over with you today, and but it will, again, we'll revisit some of these things when we do the case studies. But I wanted to just really kind of cover, the range of things that we need to consider in terms of neurocognitive and neurobehavioral outcome from acquired brain injury, and what that might have to do with inappropriate behavior that we're trying to address through the principles. So I'm going to now just give you some things to think about, okay, based on what I've just gone over. So considerations for presenting the principles. One, cognitive accessibility. So if we know, for example, that somebody has aphasia, they've had a big stroke in their left hemisphere, and we might need to think about how we need to modify the principles to be understandable to them, and what we might need to do based on the type of disorder that they have, so that they will be able to cognitively access the principles. Accommodations for individuals with visual and auditory impairments. So what other ways need to be used to deliver the principles and have them retain that information? I understand that there's been a translation of the draft principles into Spanish, but I think we need to think about whether or not those principles need to be translated into other languages if that is indicated. Cognitive supports to facilitate the retention of the information, and cueing when the problematic behaviors recur. So to really think about for that individual, what do we need to do to help them remember what you are presenting to them in the principles of engagement? And what do we do? How do we intervene and remind them about the content of those principles when, as I'm sure will happen, people are going to repeat the behavior? All right, so that's something to think about. Anticipatory preparation, particularly when you already know that that person exhibits a known history of problematic or disinhibited behavior, or these are the people that you already know engage in these behaviors. And Dr. Susan Roberts will be talking with you next week about applying principles about positive behavioral support as it pertains to the presentation of the principles. We'll also be talking with you about that in much more detail next week, and really, thinking about what is the checklist of things we should be thinking about, particularly when we know that that person has a history of the behavior that the principles are meant to address. As I just mentioned, trauma-informed approach when applicable. For example, when working with combat veterans who have combat-related traumatic brain injury and some of the environments that they have been in, some might have PTSD, and have had racial prejudices based on their military experience. This is something that we need to think about. And what is the trauma history, if it's known, of somebody that you might be presenting the principles to? Clinical consultation in advance. When you feel that I think this got brought up in the first presentation today, is to really think about when you need some help. The clinicians at DDS and at Mass Rehab, when would you benefit from a clinical consultation before you're going to present the principles? Collaboration with provider staff. We probably know that the principles for many individuals are not going to be presented in person, but it's going to be on Zoom. So to think about what you need to do in terms of collaborating with provider staff, and when indicated, the provider staff's clinical staff that may be involved with that individual, and also can be of assistance in preparing at the other end of this, and at the reception end of this at the provider level. Plan for presentation of the principles to the legal guardian when applicable. As I mentioned, and I have been made aware that some of the individuals that will have the principles presented to them have family members or significant others who are contributing to their inappropriate behavior. And so again, that's not another meeting that's going to have to be planned for. Follow-up plans with the waiver participant and provider staff, and to think about staff support, particularly for staff who have been targeted by these individuals, and what kind of support that they're going to need. And because one thing I think also needs to be thought about is, again, in those individuals where there's been a history of this behavior, to think about what needs to be done with the recipients of this inappropriate behavior, and what kinds of additional supports they might need, and to work with the provider along those lines. Finally, clinical evaluation. And I just wanted to end with that, to think about when problematic behaviors have emerged recently or they've intensified. And I've highlighted this a couple of times today about ruling out neurodegenerative disease. And, I certainly can think of people that we've had in programs in the community. They were doing fine, even people who were living on their own independently, and then their behavior was significantly changing. And for some of those individuals, they had a family history of Alzheimer's disease, and they now developed Alzheimer's disease in addition to their acquired brain injury. So just something to keep in mind, particularly if this seems to be a new behavior on the part of this person, or maybe they had inappropriate behavior before, but now it's intensified. So to just keep that in mind for those individuals who may be a subset of those that you're going to be presenting the principles to and may need a clinical assessment. And in that regard, again, these bespoke proteins that we're all used to seeing, I just wanted to say in that regard, things that have been emerging in the literature, the neurological literature on COVID, is that people with pre-existing neurological conditions are showing intensification of their symptoms and residual sequelae related to their brain injuries, or some of those individuals who've had progressive disorders like Parkinson's disease and Alzheimer's disease. But the other thing that's coming out of the COVID literature is also because COVID, again, entering the nose, going to the frontal lobes, this is why people are having anosmia, is also leading to a kind of personality disorder. And so again, some of the folks that we serve have also now had COVID. And so if something is now, they're exhibiting behaviors that you didn't see before, or things seem to be intensifying, again, think about whatever the contribution might have been of a COVID infection. And of course, hundreds of papers are coming out every month on the neurological impact of COVID. And this is one of them. And people are describing a personality disorder that actually can look like these frontal lobe syndromes that we have been discussing today.